and welcome back to this episode of This Healthy Life podcast. I'm so excited for my guest today. I have Dr. David Amron, and he is a dermatological surgeon with over 30 years experience treating lipedema. He is also the founder and medical director of the Roxbury Institute and such an amazing advocate for the lipedema community. And I personally want to thank you for that, because your education of different practitioners and just spreading the word about what lipedema is what led me to figure out that I had lipedema. So I really appreciate all that you do for us.
That's why I'm here today.
That's amazing.
To spread more awareness.
Absolutely. So I'd love for you to start just with a brief intro. How did you even get into discovering lipedema and wanting to work in this community?
Yeah, I get asked that a lot. So it was a interesting marriage many, many years ago. So when I began practice 31 years ago, I decided to focus my whole practice on liposuction, all different aspects, a lot of complicated areas that nobody was doing, like calves, ankles, and forearms. And I really developed the techniques for these areas back then. And that led a lot of patients with calf and ankle liposuction to find their way to me. And I then did one of these European makeover shows over 20 years ago. My ex-partner, Dr. Paul Nassib, was on that botch show. And he was doing all the facial plastic surgery. I was doing all the lipo. And I had two patients where I was doing calf and ankle lipo on them. And it was shown in Europe. And all of a sudden I had all these women from France and Germany and England come to me and say, Dr. Amron, I have a lipedema. I want you to make me beautiful and treat my lipedema. And I'm like, lipedema? You know, it's like the same thing I do over and over again, you know, the whole way I do circumferential calves, ankles, and thighs. And I began to then realize that even for the years before, I was really treating lipedema. So it was really kind of a great marriage of my skill set and patients not having anywhere to go.
And patients that you already kind of had some experience with too, but just didn't know what it was yet, right?
Yeah, exactly.
Yeah. So why do you think, I mean, it's such a common disease, right? 1 in 9 women have it, which is just insane to me that it's that high of a number. And why are so many doctors just not aware of it? I mean, obviously they're not really taught about it in medical school, but so many women are affected by this. Where is the lack of education coming from?
Well, I think it's that. I think it's lack of education. I've said there's this pervasive ignorance about this disease. And I just use that word ignorance, not like stupidity, but it's been ignored. And, you know, one thing that I do when I do the consultation on patients, the first question I ask is, when did you hear about lipedema and how was that? And 90 to 95% of the time, it's on the internet or essentially self-diagnosis. It's unfortunately not from other healthcare professionals or MDs. And I really think it goes back to us not being taught that in medical school. And lipedema never made its way into the medical curriculum. It was identified in 1940 at the Mayo Clinic. There was great papers written about it. I think it was given a kind of a weak name, lipedema, that kind of sounds like some made up thing. Lipa and edema, it's kind of fat and swelling, and it gets confused with lymphedema. And it just kind of got glossed over. If it doesn't make its way into the medical curriculum, as a physician, as I've said this many times, years later when you hear the term, and you go back to this Rolodex of thousands of diseases that you learned, it just wasn't there. And that's a big problem. Really, it was not taught in medical school. And we'll talk about this. I began a nonprofit organization, Lipedema Society, that is going to be the leading medical society for lipedema in North America. And one of our main causes, besides awareness and insurance reform and standards of care for surgery, is making sure that it's taught in medical schools.
Amazing.
Hugely important thing.
It's so important because, I mean, obviously the earlier you catch it, the more you can do about it, right? Because so many women just make it to these late stages, and at that point it's harder to kind of come back from all the damage that's been done from lipedema growing for so long.
Absolutely. I mean, that's a whole thing. I mean, it needs to be, picked up earlier. I've said that OBGYNs, pediatricians should be screening for it at a young age. But, the sad thing is it's 1 in 9 women. That's a high number, and it really is that much. And many patients, doctors every day, every week are seeing patients with lipedema that have the opportunity to diagnose them, and they're not diagnosing it. They're missing the diagnosis.
Absolutely. I mean, just in my own journey, when I started really having issues with lipedema, I mean, I obviously think I had it for a long time, but I think it was very localized just to my thighs and wasn't really that big of a deal. And then after I got stem cells for Lyme, something triggered it. I gained like 50 pounds in 6 months, and no matter what I did, it wouldn't help. And I went to so many doctors in 8 years, and I was like, I feel like I have water retention that turns to fat, and it's tied to my hormonal cycle. And doctors would just look at me like I was crazy. One doctor even told me I was having a Barbie moment, that I looked fine fine. So it's just like,
Yeah.
and you're gaslighted by your medical system for
Yeah.
this prevalent condition
Yeah.
that exists and is affecting so many women. And you have doctors like this that are just, you know, dismissing you, gaslighting you, or telling you to eat less, exercise more, which does nothing for lipedema. It's really, really horrible.
It's a big problem. It's really horrible. And I think that it really plays head games at a minimum with women's minds. At a maximum, it creates eating disorders and stuff like that. Unfortunately, the average age I'm diagnosing patients is about 50. I mean, sometimes it's 20 and 30. That's great. But a lot of times it's 16, 17. These women have gone through a lifetime of kind of pain and trauma and misdiagnosis over and over again.
Absolutely.
Big problem.
Absolutely. Well, thank you for advocating for us and starting the nonprofit and you know, starting to educate, because it's so important.
I think I feel a big responsibility to be doing that.
So I'd love to talk a little bit about the Roxbury Institute. So you're the founder and director, and you've kind of developed your own program for helping women with lipedema. Give us a little bit of insight into kind of your approach and how you treat women.
Yeah. So it began much more with me just doing surgeries on patients with lipedema. And, you know, perfecting my own approach that I've got a patent pending system in terms of how to go about it. We can go into more of the details of that, why it's unique and stuff. But it's just grown and expanded over the many years. I've been doing this for 30 years. And now I'm proud to say we have such an amazing program. We really are the leading therapeutic center for lipedema in North America. We get referrals from academic centers, Mayo and Stanford and Harvard and stuff like that. And they really, unfortunately, don't have it going on. So we have a really structured program. We now have a center in Los Angeles, Salt Lake City, Utah. Karen Herbs heads our diagnostic and preventative center in Tucson, Arizona. And so it's not just only about surgery. It's about the comprehensive care of patients. We certainly excel at surgery. And in surgery, it's not just only me. I've got a whole team of even the surgical centers themselves. They come in, they're highly trained, the technicians or technologists, the anesthesiologists. I use the same team over and over again. We have all these protocols. I've got clinical nurse practitioners, decongestive therapists. So if you're going to get into lipedema surgery, you really don't want to dabble. You want to really focus your practice around it and go very deeply into it with all the protocols. But now it's not just surgery, it's diagnosis and prevention of lipedema. I think that's the next important frontier to get into. You know, what can be done to slow the progression of it? We'll talk about the supplements and stuff like that.
Yeah, I'd love to hear a little bit about that, because I mean, that's such a thing, right? Like, I feel like you get lipedema and there's nothing you can really do to stop it other than maybe some conservative methods, which sometimes work, sometimes don't work, right? Or you, like in my case, before I even knew I had lipedema, I was doing like lymphatic drainage and doing all these things, and like it felt like a Band-Aid, or it like slowed it down for a day or two, and then all of a sudden like it would just keep coming back, right? And I felt like I was on this treadmill that was just going to get flung across the room at some point, because I just couldn't keep up with it, and it wasn't making that big of a dent anyways. So do you kind of see that there's going to be some alternatives to surgery eventually, that there's going to be some other kind of preventative things or things that can kind of slow it down and buy you some time before maybe you have to have surgery?
The quick answer is yes to that. I think that prevention is hugely important. Not every patient should be just jumping into surgery. So you want to do everything once it's diagnosed, hopefully at a young age, to slow the progression. There's a lot of dietary strategies that are important, compression therapy, other things that can be done. The use of potentially GLP-1 agonists, which we can get into, like Mounjaro and stuff. But it is important, identifying what can be done to slow the progression. And it's also important after surgery too. It rarely comes back, but you want to do everything to responsibly to prevent the condition. So it is important. I think that it's going to be a difficult disease to just come up with a medication for. Understanding the pathophysiology of the disease, that it's not just going to be, one pill you can take for it. I think it's going to come from many different areas in terms of qualitative prevention for the disease itself, because again, it's not just only fat. This is something we can really get into also. Lipedema is not just simply only about fat, and it also is not like a cancer that just progresses and you've got to remove every single cell. It's a process involving fat, inflammation, metabolic changes, and lymphatic weakness. We know that the weakness of connective tissue is definitely involved in lipedema. And honestly, that's going to be a difficult thing to repair because you have a structural defect genetically of connective tissue that is involved in lipedema. And not only involved, it's probably the primary thing going on.
I'd love to dive a little deeper into that because that's the first I've kind of heard about that. So, I mean, yeah, like you said, right? Usually you think it's like this fat and water retention and swelling, definitely like a lymphatic component, but let's dive into the connective tissue component and what's kind of going on there.
Yeah. So lipedema, it's not a bad name. If you break it into...
Should we rename it? Should we rebrand it as part of your efforts?
I've said this for over 10 years. Karen Herbst does not want me to say this anymore. We talked about it in Germany a couple of years ago. I literally stood up and said, we really need to change this name. I voted for the name lipofibroedema for a number of reasons. First of all, it sounds more like a real disease. Lipedema sounds, it doesn't get confused with lymphedema.
Yep, absolutely.
It really speaks to the three elements of lipedema, which is the lipo, the fat component, the fibro component, which is the connective tissue and inflammation, problem with it. And that really is one of the big problems. The fibrotic component and the scar tissue plays havoc with things. And then finally the edema. So I would like to have called it lipofibroedema, but it's too late for that, as Karen tells me, because it's just too embedded in the literature now.
Enough people have finally started hearing about it, right?
Right, they finally started hearing about it with things like this, and also the insurance companies. We have been better and better in terms of training them to understand this is a disease. This is another very important topic in terms of how insurance companies are now finally recognizing it. It's not a slam dunk, it's still a challenge, but so to rename it, it's a problem. So we live with lipedema.
we'll live with it.
Yeah, but to go into some of the pathophysiology, this is what I think is going on with lipedema. There's been a lot of very good research. We're involved in a lot of research clinically in basic science. Certainly Karen is huge with that. If you really look up, who's done most research in the world on lipedema, it almost always goes back to Karen Herbst. That's why she's such a pillar of lipedema, clinically and research-wise also. But this is my understanding of lipedema. I think that it is a genetically inherited and even genetically inherited is what we call autosomal dominant specifically. You pick up a gene directly from a parent, and an equal frequency, a mother or a father could be carrying the gene. Okay. It's very interesting right there.
Both sides.
It's very interesting that there's many men walking around with lipedema as women, but they rarely express it unless they have hormonal fluctuations and stuff. So I've only done surgery on maybe 10 or 15 men with lipedema.
Versus thousands of women.
Yeah, thousands of women. But if a man's carrying it, he won't show signs of it very, very rarely. You got to look at the females, his mother, his sisters, and you'll almost always find evidence of it.
And does it present the same in men as it does in women? Do they get kind of like the same
good question.
Shape in their body and cuffing and symptoms, or a little different?
Kind of. They are more prone to swelling. They generally have disproportion. Typically, they're going to have it in their thighs and their hip area. When I've seen it in men, sometimes it can be very subtle, where it kind of wraps around the leg also, like it does in women. You lose the shapeliness of things. Sometimes they will have symptoms with even tenderness and stuff like that goes on with it. Commonly, you'll find the hyperflexibility in them also with it. So, if you dig deeply, you can even start to see it in men too. Yeah. But going back to the pathophysiology, so this is what I think is going on. Genetically inherited defect of connective tissue at its primary core.
It's kind of the root of it.
I think so, because you've got many other things that point to it. You've got leaky lymphatics. That was discovered in 2016 by radionucleide studies.
That's
where
it?
You've got
Just
fluid.
2016?
Yeah, 2016.
Wow.
I remember when it was
so
presented.
New.
Fluid moving out into layer of fat. So leaky lymphatics. You'll get deposition of stem cells that migrate out. They find themselves in the environment of other fat cells. They differentiate into fat cells, first pre-adipocytes. They begin replicating. You get inflammation to the replicating and dying off fat cells, but it's not really an autoimmune process like other things like lupus or rheumatoid arthritis, and that begins a process of fibrosis. So you've got leaky lymphatics, you've got fat turnover, and you've got inflammation all playing a part. That's why the term lipofibrodema really makes sense. And then it begins to just develop a mind of its own. You get in a vicious cycle of what's going on. You get increased hydrostatic pressure in the tissues. That will begin to move more fluid out. That's why you'll begin to see what I call secondary areas of involvement. So I look at lipedema as primary areas and secondary areas of involvement.
So what does that mean? What does that look like?
Yeah, so good question. So this goes into a lot of depth of things.
I love it.
I hope your readers are knowledgeable about lipedema because it's a lot of information.
Yeah.
So there's different stages, 1 through 4, the different types.
Yep.
Type 3 is a common type column like lift legs. Type 2, which many times is missed, more of a triangulated pattern down to the knees. So in type 2 patients that have the hip and upper and thighs involved, as years go on, they will tend to get secondary involvement in their calf and ankle area. They can also get secondary involvement in their torso area also with it. So the torso can be involved in lipedema and many times is, and many times needs to be addressed because you don't decongest proximally, you're not releasing that lymphatic circulation. Upper arms are primarily involved, but usually years or decades later. So if your average patient will say, began in my legs or my hips or even my calves and ankles.
Me. Yeah. I was like, I just have strong thighs. I'm like,
right.
So like now I know better.
That will generally present, at puberty with the hormonal changes, sometimes a little bit later in the teenage years. And then typically later on, or not typically, predictably, the arms will begin to get involved, but it won't generally happen in the teenage years. It'll happen later on, the 20s or the 30s or even the 40s. The arms will begin to get that same circumferential fullness going on.
And why do you think that happens? Why do you think it kind of just generally starts in the lower limbs and then starts to progress to other parts of the body?
Yeah, let me just finish this.
Of course, sorry.
So, and then secondarily, the forearms can begin to get involved with things like that because the increased congestion here, it will begin to increase the hydrostatic pressure. That process will begin to then move on to other areas. Why does it begin in specific areas? So you see that characteristic disproportion with lipedema. Column like look to the legs, upper arms are involved, type 2 patients going down to the knees. Generally, patients inherit a certain pattern from the generation above. So type 3 patients, usually their mother or father will also have a type 3 type of pattern with things. Why it presents in those areas, it has probably most to do with lymphatic flow. I think lymphatic congestion and moving of fluid in certain areas as opposed to other areas until it just goes so far gone that you're kind of seeing it everywhere in patients, even the torso, even the neck and the face.
I've started to see
patients.
that people are experiencing that.
Yeah, because, again, it is a systemic condition. Patients with lipedema have other areas of connective tissue weakness. Ehlers-Danlos, the hypermobile joints in most patients, leaky gut syndrome in a lot of patients. A lot of these patients have been misdiagnosed, which is simply leaky gut, when it's really kind of part of lipedema because you have weakness of connective tissue around intestinal membranes. Brain fog, kind of just a layperson's term, which is really swelling in the central nervous system that is creating some of that brain fog. Again, you've got swelling because of leaky lymphatics in the central nervous system.
And there's a big mast cell component as well, right?
That's a whole nother
researching as well.
Nother big area to understand.
It's a whole other podcast episode. We won't dive into that.
Podcast episode is something that I've become very knowledgeable about in the last few years. The whole contribution of mast cells and the inflammatory part and how it plays in to lipedema with inflammation and makes things worse.
Absolutely. So I want to switch gears a little bit and talk about some of your approach to how you do surgery. So, obviously liposuction is the way you do surgery for lipedema, but it's very different from traditional liposuction. And you've kind of created your own program that's very conscious of being aware of the lymph system and making sure not to damage it because it's already damaged from having lipedema, right? So I'd love for you to share a little bit about kind of your approach to how you treat lipedema with liposuction.
Big area. And I'm going to plug my book right here.
Sure,
so there's a book I
do.
have, it's lying around here somewhere, which really goes into a lot of detail about my technique. So for your viewers that want to understand, there's all these chapters about understanding the role of liposuction and then lipedema, and it goes into everything and in great detail. But lipedema surgery is different. I mean, it's liposuction, but it's dealing with a different population of patients who have a disease, a condition, where you're understanding that in terms of how it presents in these complicated, strange areas that are commonly not done with lipo, like forearms and calves and ankles. You want to maximize the disease treatment and functional component, and you want to also maximize the cosmetic component. We can talk about that in terms of how you really want to maximize both in every patient. You're dealing with a disease that has not just fat involved, but has fibrosis. Now that's a very difficult thing to understand how that plays in with it, and to deal with surgically, because if you don't understand how to deal with fibrosis really well, and many surgeons say, oh, I understand fibrosis, but there's different patterns of fibrosis with lipedema. There's nodular, there's dense, there's strandy, and there's granular. And I define these different areas.
Kind of connected to your connective tissue at that point too, right?
It is, and interestingly, that each person will tend to inherit a fibrotic pattern from the generation above. It's one of the areas that we're going to start focusing research on. It's really interesting to understand fibrosis, because the swellers will have a strandy pattern of fibrosis. The ones that are prone to lipolymphedema, which is damage to the lymphatic circulation, are going to have that dense type of fibrosis going on that can play havoc with things. So, understanding fibrosis, how it plays into it, is important. Understanding that it's circumferential, another way in which I go about doing that's very unusual and unique. So with lipo, typically you're going to hit kind of hot spots, your outer thighs, saddlebags, inner thighs, back of the upper arms, surgeries, the abdomen. I developed this whole circumferential 360-degree way of doing things, because with lipedema, you're dealing with a circumferential disease process. So it's a proper and better way of treating it completely, but it's definitely better from a cosmetic standpoint.
Make sure you get everything out so it doesn't come back too, right?
Yeah, I mean,
as much as you can, at least.
Yes, I mean, but almost, also as much as you can type of thing. If you're overly aggressive in the raw patient, just thinking of lipedema like cancer, like you've got to eradicate every cell, you're going to end up with a lot of cosmetic issues in patients. So you want to always be smart and temper things. And again, it's not only about removing all the fat. It's about really treating the fibrosis completely. In fact, I'm going to say that the fat is not really as defective as people think. They're really younger, healthy fat cells doing their thing and turning over. And what is a testament to that is that I do fat transfer with lipedema fat successfully and safely over and over again. So you can take that lipedema fat, you can purify it, and you can use it for fat transfer in other areas in patients that can benefit from it without ever transferring the disease process itself.
Okay, that's really cool. That's interesting, because you would think that you have this fibrotic fat, you just want to get it out, right? You don't want to put that back into your body somewhere and potentially cause growth in a new area that didn't have an issue.
Yes, and I began to that over 10 years ago, and was I extremely thoughtful about it? Yes, I was. Was I very careful about it? Yes, I was. Was I a little bit unsure about things and I approached it very carefully? Yes, I did. Just the way in which I've done everything surgically with it. But unless you advance things, unless you advance certain things, you're never going to advance things. And you just do it with a lot of gestalt understanding experience. You carefully advanced areas, and that's exactly what's going on with lipedema surgery with me.
Absolutely. And then so let's talk a little bit about revisions and people that are coming in maybe for a second time of liposuction, because I feel like there's a lot of women that don't realize they have lipedema, right? And they're just like, I don't know what's going on, I'm going to get lipo and see if it helps. And it's not that kind of circumferential lipo. It's not really taking into account that they have this diseased fat, and then all of a sudden they're like, oh, it didn't work, right? So do you get a lot of women like that have tried liposuction or have gone to other surgeons and then come to you and are like, hey, I know I have lipedema now, what do I need to do?
Yeah, and I'm gonna answer this in a careful way, because I think that it's so I'm seeing probably about 25 to 30% of my patients now are what I call revision lipedema surgery, more than I did years ago, because nobody was really doing it years ago. Now you're getting more and more people entering into it, and I think that's a good thing. But I think that if anybody's going to take on lipedema, you better be prepared. You better have really a lot of your skill set to a high level. you better have understood and learned things in a good way, but that's a little bit challenging because where do you really learn things? And you better have your practice dedicated to it and focused. And it's not something that I think people should be dabbling in. So I would just caution the dabblers about advertising for lipedema when you're not really prepared to deal with all different components of it, because there are very complicated patients with lipedema with stage 4 that you may not be prepared to deal with. You've got to have decongestive therapy set up properly in-house. You've got to have your program really highly defined and stuff like that. And unless you understand things, you're going to have increasing problems with it. Unless you really understand how lipedema presents, where it's presenting, where it's not presenting, you're not going to treat it completely. You're going to cause potentially cosmetic disfigurement. You're not going to treat complete units, and you're just going to end up doing a disservice to the patient, really. And I'm seeing more patients like that. And so it involves going back and making improvements and corrections. A lot of times it's doing the area completely over again, starting from scratch with it. Sometimes it's caused a great degree of cosmetic disfigurement in areas that shouldn't have been done, where you've got to do fat transfer. So I think there should be more surgeons doing lipedema surgery, but I think that there should be proper training for it, proper certification for it. It's one of the things with Lipedema Society that is highly on our radar in terms of certification for it, proper training for it, and so that the public and patients with lipedema can have a degree of confidence of who they're seeing is really qualified to do lipedema surgery. I be careful about kind of quick marketing for it and quick fixes for it, just like anything with cosmetic medicine. Take your time, understand, do your research before you make your decision. Lipedema patients, in my experience, are great at that in general, much better than the cosmetic patient. They generally are what I call deep researchers.
Yeah, because you've had to rely on yourself for so long as a medical system. Kind of feels you like figuring out what's wrong with you, right?
A lot of times they've been the ones that have diagnosed themselves. In fact, most of the time, 90%, they've essentially self-diagnosed themselves.
I'm pretty sure I have it. Just confirm for me,
please. And they usually do. It's what I call the aha moment. So they are proud of the research they've done to find they have this thing. And so, but also they've been messed up many times. They've been misdiagnosed. They've spent money on things. They've gone down rabbit holes that are wrong rabbit holes with things. So they don't want to be messed up again. So they're going to take their time to understand things. And I think that's great. And so education is really important. And, even what I do, I try to make everything educational. I try to make everything about understanding and guiding and not about look, here's lipedema surgery tomorrow. Come and see me. I've got a 2-for-1 special and stuff like that. Be careful about that stuff.
Absolutely. Yeah, really do your research. Find qualified surgeons that are out there putting out good information, right? Absolutely. With everything, not just lipedema.
With everything. With everything. With cosmetic medicine, with everything. Choosing a plumber, choosing a contractor, everything in life. Everything.
Exactly.
Take your time, It's like the older I get, the more I realize that, unfortunately, the minority people are really actually outstanding at what they do with things. And just take the time to try to find that. And I try to say that, listen, I think highly of myself. I'm very proud of what I do. And I say that with, a certain degree of humility. But, just take your time.
Yeah, absolutely. For sure. And I want to talk a little bit about some of the other conditions that kind of go with lipedema or other kind of fat disorders, right? So we don't have just lipedema. You mentioned lipolipedema. And then there's Derkham's disease, and there's a couple others, right? So how are those?
Madelung's or benign familial lipomatosis.
So how are those all connected? And do patients usually present with more than one fat disorder?
Great question. We're still trying to figure all that stuff out.
Yeah.
It still is. So fat disorders is a big area. And Roxbury Institute, as I've said, this is not only just, leading center for lipedema, but we really specialize in fat disorders. So I see a lot of patients with Derkham's disease, which we're going to talk about, Madelung's disease, certainly benign familial lipomatosis. And they are essentially, different discrete disorders. So there's lipedema, which is mostly what we're talking about, which is the most common of the fat disorders. There's lipolymphedema, so it's important to get terminology correct. So there's in that realm, there's lipedema, there's lymphedema, which are two separate things that can coexist And then there's lipolymphedema, which is lymphedema that is being caused by long-standing lipedema that has damaged the lymphatic circulation. Okay.
Is there any coming back from that? Is that one pretty damaged?
Well, it depends how much damage.
Yeah.
Okay, so I think that if lipo is done properly and correctly with certain techniques and this and that and vaser and this and that, you actually, by properly releasing the fibrosis carefully, can begin to free up lymphatic circulation. So I think if it's not too far gone, you can make improvements, typically surgically with lipolymphedema. Therapeutically, I think there's a role of things like GLP-1 agonists and things that can improve your inflammation. Dietary changes, possibly supplements that can begin to possibly reverse some of the changes of inflammation. But if it's too far gone and things are just completely scarred down, it's a problem. Talking about the other fat disorders. So the next one is, let's just start with benign familial lipomatosis. Typically it's autosomal dominant, again, picked up by a parent. Basically it's multiple lipomas throughout a person's body. Generally not tender. So that distinguishes it from Derkham's disease, which we're going to talk about. Typically on the extremities, but can occur anywhere. There could be dozens of them or hundreds of them. It can be problematic because typically with them, you're going to have to go in and make small incisions and pop them out and do it, in as cosmetically, elegant a way possible. I like to use lipo as a way of initially treating benign familial lipomatosis, and you can really break up those lipomas very, very well with proper techniques of lipo. Typically, I use vaser and other things that are going to emulsify the lipomas, and then the ones that have not responded, you can go in and make an incision and remove them. So that's benign familial lipomatosis. Madelung's disease is a less common condition, very rare. And I think Madelung's, where you've got typically fullness in the upper back area and shoulders and upper arm area, I feel it's almost an offshoot of lipedema with a different pattern of lipedema. Typically, it responds well to liposuction and done in a certain way. But Madelung's is pretty rare. Okay. So it's not too much. Derkham's is more common, not as common as lipedema. Can coexist with it. Derkham's was defined by Francis Derkham in the 1800s, and it was very well identified. And it basically are painful lipomas that can exist all over the body, more common to be in the truncal area, but can be extremities also, and typically very painful. Not just painful to touch and pressure like lipedema is with its nodules, but just typically painful all the time. The pain can be even 9 out of 10 pain. Very difficult. Derkham's hard to treat. Typically, you'll go in and make excisions to remove them. I've done quite a few patients with Derkham's. Typically, I'm going to give liposuction an opportunity at first to make improvement in it. And it typically does, and only the recalcitrant ones go back and make an incision and remove them. Yeah.
It's so interesting. There's all these fat disorders, but I feel like there's not really like a fat doctor, right? Like you go to if you have a heart issue, you go to your cardiologist, skin, you go to your derm, right? But who treats the fat disorders? And so it feels like there's this kind of gray area in our medical system that no one really addresses this unless someone finds it like you, right?
That's right. And that's why, I see this path to really being, leading center in fat disorders, not just lipedema, but fat disorders, because nobody's really addressing it. And not only just surgically, but, Karen now on board, it's amazing because Karen was so involved with Fat Disorders Research Society. She has such a soft spot in her heart, but also research-wise for Derkham's disease. So Derkham's patients have had almost nowhere to go in North America. Karen has been the only real person that specializes in Derkham's. So, I really see that this advancement of what we're doing for fat disorders and even, the use of GLP-1 agonists with things. And it's interesting use in patients with fat disorders, especially lipedema. We can go into that.
Yeah, I'd love to
talk
about that. But I
see that, patients that have lipedema that can benefit from GLP-1 agonists, they really should be ideally coming to us in terms of things with it, in terms of how it plays a role in their therapy. I like to consider after surgery in many patients. Karen likes to consider it before patients, before surgery in a lot of patients, especially the patients with a lot of inflammation. So we have all these protocols that go on now in terms of how and when we use GLP-1 agonists.
Yeah, I've been using one after my surgeries, and it's definitely been a game changer for swelling and any residual inflammation, and really kind of like a magical treatment almost, just to kind of really help maintain those results and help with inflammation and even just like the texture of my tissues, right? Like it's like when I would getting my manual lymphatic drainage, they're just like, what's different? Why does your tissue feel so different? I'm like, oh, the only thing I added in was microdosing terzepatide, and they're like, your legs feel completely different from what they normally feel like.
I think it is a hugely interesting frontier. My experience is that it definitely has a role with lipedema. The role is variable from one patient to another. Some patients respond really well. Maybe those are the patients with more inflammations working a certain way. I think it generally has, in most patients prior to surgery, they're generally going to lose weight, but generally not as much in the areas of lipedema. Generally, it's going to be more in the areas where they don't have a lipedema. So they might lose 20, 30, 40, 50 pounds, more of their so-called regular fat in their torso. Lipedema, generally a little bit less so. But then there's this interesting percentage.
It's working on lipedema fat a little bit too, huh?
Well, I think it is, but some patients just, I got to say, just did not respond to it. And maybe those patients are the ones I'm seeing for surgery that have failed their GLP. They've been on for a year or two and they just haven't seen any change with it. But then there's those patients who've been on it. Maybe it's 5% that just had a dramatic response, even prior to surgery. Maybe don't even need surgery possibly. Then there's the patients after surgery that you're going to reserve it for 6 months after surgery for further improvement with things. I think microdosing is a really interesting area with it.
Yeah, it's exciting. Exciting that it's actually helping us, right? Because it's like so many women with lipedema try so many different things and they're like, I've tried everything, nothing's working. And like to have something that is helping a big population of women with lipedema is really powerful.
Yeah, my only caution is that I will say this. If a patient goes on it, especially ones that are more advanced, the younger patients that have, let's say, stage 3 lipedema that are very inflamed and they're not seeing improvement with it, don't waste too long on it. Don't waste, years on it and just, this and that, because the process is still going on. And those patients need to be interceded with surgery with it and make that improvement and remove it and decongest things and that fibrosis and then maybe use it as a tool afterwards.
That makes sense.
And that's my only concern, that the people with lipedema are hearing the message, let me just go on GLP-1, this and that. And some of those patients may be wasting time with things.
No, I totally agree. That makes perfect sense, yeah. And then so speaking of inflammations, I want to talk a little bit about a new supplement that you're kind of putting out into the world for women with lipedema. I think you have 3 different ones. I'd love for you to share a little bit about that, some of the science behind it, and what you kind of foresee that doing for women.
Yeah, so I've been working on this for close to 3 years now. It's been a whole process with things, kind of putting the whole thing together. It began with the idea that patients with lipedema really should be doing everything preventatively as much as possible. We have, the dietary strategies that are important. That's a whole important area in itself. What to avoid: gluten, grain, sugars, alcohol, probably dairy products, and then there's all these little fine tuning of things. The compression strategy, preventatively, which is very important. Understanding how compression plays a role in lipedema preventatively. Compression garments, pump therapy, lymphatic massage therapy, the advanced patients bandaging and wrapping, other things like vibration plate therapy and fascia blusters and stuff like that. But supplements, I think, are an important area with things. Not like it's the end all and be all with it, but if you're trying to do everything to slow the progression of it, I think it's got a hugely important role. There's a number of supplements that have been very research backed with things, and actually Karen Herbst has done a lot of research on a lot of these ingredients, even before that we joined forces of it. And so I put it into a program, which is really a program. It's not just, I start with this concept, you can just take, 1 or 2 pills a day, almost like a 1-a-day vitamin thing. And I realized quickly that there's so many components to this thing. And as I thought through this, I said I want to target the 3 pathophysiologic areas of lipedema. I want to target inflammation, because it certainly plays a role. I want to have something for lymphatic support, because that's part of what's going on. And then metabolism. the fat turnover that goes on with lipedema. And that's what the program is. It's anti-inflammatory, it's lymphatic support, it's metabolic. It's a 3-time-a-day program, AM, midday, and PM, and it targets the three areas of lipedema.
Amazing. And so when are those going to be available? Are they out now?
Very, very soon.
Okay, good.
Very, very soon.
Awesome.
So we've announced it. It's not quite available for purchase, where there's a lot of information about it. I think we're taking emails and stuff like that for it. It is going into production now. It should be available in the next month or two at most.
Okay, amazing.
So we're in mid-June.
Yes.
So it should be available by the end of July.
Awesome. Okay. Perfect. Amazing. And so you talked about all the incredible things that you're doing in the operating room and helping women, but you're also doing amazing things outside of the operating room, in addition to, creating these protocols and supplements, and also about your nonprofit. So I'd love for you to share a little bit about that and kind of where you're at in the space of helping educate even more than you already do about lipedema.
Yeah. It's getting to be more, much more of a big thing. And I don't really have to ask myself what drives me, because I really do enjoy it. It certainly is a lot of work. I feel a responsibility for it, and maybe that's it. I feel like a really responsibility to really advance a lot of areas, therapeutically, surgically, insurance reform with things like that, educationally. What I do in my center is comprehensive care, but my latest passion that just enters into the mix of things is Lipedema Society. And I think that I at this point in my life, and I'll be 65 my next birthday, I have good genes.
You do.
My father was 101, my mom was 97.
Wow.
They passed away a few years ago. And kind of spiritually, I feel this need to, I can't make them proud while they're here, so I hope I make them proud, in the world to come. And the actions we do in this world physically, really spiritually make changes in things. And they can't make these physical changes, so I want to do it for them. So what I do in this part of my life is very important. I'm looking to, I guess, build a legacy with things, that when I'm no longer here, that things live on. That's been that way with Roxbury Institute. And now that we really have physical centers that are going to exist, the buildings and stuff like that, I'm very proud of that. And Lipedema Society is the next area that is my passion with it. So let me talk about that for a few minutes. Lipedema Society was an organization I developed in 2015, and it started with the idea initially to increase awareness for lipedema. There really wasn't any leading organization doing that. There were little spatterings of it. Lipedema Foundation, which I have a lot of respect for, was leading research with things with lipedema. And they do great work supporting research. And they've gotten into awareness also. But there's still a need. There's this missing need for in the lipedema community. And so identifying what that need is, it really falls into different areas. One of it we talked about surgically, that it's a little bit like the Wild West out there. You've got no real certification, no board, you've got no real medical society focusing on this. Who do patients know to go to with it? My story is a little bit interesting in terms of it, because nobody was doing it. But, nowadays people are looking to jump on the bandwagon. A lot of it is just, I hate to say, financially. They're seeing an area that they can incorporate in their practice. So that's one area. Certification is a huge, important area for Lipedema Society to lead. We're going to develop certification criteria, certain number of cases, testing, and stuff like that. Another area is insurance reform.
It's a
and advocacy, which I've been doing with my practice, Roxbury Institute. There are others doing it too. I have to give credit. Stanley Roxon, I and Karen Herbst were involved in a big class action case many years ago with the Blues that began to change how things were written in their policies, and that began to really change things. But that needs to get better, with the insurance companies. So a big part is insurance advocacy with Lipedema Society. Another part is education and awareness. And certainly the community is part of it, but healthcare providers. I mean, what's going on here? You know, it's still, I think, less than 10% of physicians really know about lipedema. And that's got to change.
Yeah, that's extremely low.
We need to get it taught in medical curriculum. Another hugely important immediate goal of Lipedema Society, taught to other physicians, increasing awareness among physicians. So Lipedema Society is something that I founded. We are now finishing up our board of directors of it as a nonprofit organization, our major fundraising event with it. But Lipedema Society is something I'm really proud of. It's a lot of work. It's not easy. You're pulling together a lot of people, a lot of personalities. I'm trying to do it the right way. It's not just surgeons. It's leading clinicians and researchers and people who understand the organizational structure of something. It's not ego-based stuff. It's actually trying to put the ego aside from things and to keep your own businesses separate from it. It should exist as a pure entity. So I feel this responsibility to do it. And if I don't do it, I feel like it's not going to be done as well.
Right.
Or somebody, might do it with lesser true, noble intentions than I really have for it.
Amazing. Dr. Amron, thank you so much for sharing all this incredible wisdom and everything you're doing for the lipedema community. Again, so grateful to you. And if people want to find you online and learn more about Roxbury Institute, how should they find you?
That's the toughest question for me to always answer. First of all, are we done? They went that quickly?
Yeah.
Oh my goodness.
That's 45 minutes.
Wow. Well, first of all, I want to thank you. You're great, really.
You.
And thank you for everything you're doing for increasing awareness and education. And this type of platform really reaches a lot of people, and I think it's great. And it's great for you guys out there to be listening. And I would just say that everything you can do to increase awareness for lipedema, do talk about it, talk about this misunderstood disease. But how to find me? Let me see. David Amron, MD. It's I've got an Instagram page, as I'm told, out there.
We can link to everything in the show notes too if you don't have it memorized.
David Amron, my Instagram page, Roxbury Institute, Advanced Lipedema Treatment.com. There's a website dedicated to lipedema. You can Google my own name and find a lot of information. You'll find my book out there, the supplement program.
Amazing. And we're going to link to everything in the show notes as well. So thank you so much.
All right. Great. Thank you so much.